I call now Rolando.
Okay, this is amazing that we have so many people interested in IPL, but I want to do a little experiment here. So how many people here are doing IPL for dry eye right now? Okay. How many people here were doing IPL for dry eye 5 years ago? That's pretty good. How many 10 years ago? So, you know, I can go here. So I think you have to know the past to understand the present and then understand where you're going and where we're going with the future. And I think you have to understand like how I got into IPL so that you can kind of understand where ophthalmology fits in this. So when I started my practice 25 years ago, there was three things that I was interested in. I was interested in ophthalmology, I was interested in aesthetics, and I was interested in anti-aging. So what I did is I created a clinic that was ophthalmology, but I also created an aesthetics clinic where I was concentrating on wellness and all the different type of aesthetics procedures that were out there. So things that we were doing in that aesthetics clinic were Botox, fillers, erbium lasers, and then I heard about this IPL. And what was IPL used for back then? It was used for rosacea patients. So we had a bunch of rosacea patients who their face was red, they were inflamed, and they wanted something done. So what I was doing is I was doing ophthalmology, and then I would go to the aesthetics clinic and treat these patients. So what I noticed in the rosacea patients is that they were coming back to the clinic, and not only was their skin better, but their glands were working better and they were making better tears. So go to the year 2000, and I thought, okay, we should do a study about this. And I applied for an ASCRS grant, and then we started looking at could IPL be used for dry eye. Now, immediately, the one thing that I was seeing is the technology that we had for IPL, and he did a great job explaining technology, wasn't the technology that we have now where we can control pulse width and energy and thermal relaxation time. It was just one big flash of light. So you'd get one big flash of light, and the patient's skin would be very red. We actually would have to ice the skin down because you could burn it. We would we would put cool gel on so that we wouldn't burn the skin because the IPL system was so hot. And the first study that I ever did, it wasn't showing that we actually could get patients dry eye better. So then we had to start working with pulse width and energy. So I called the engineers and I go, look, you know, we're dealing with really thin skin around the eye. And if I can get energy closer to that skin, we may be able to make this a procedure that we could use for dry eye. So that's when we started changing things and changing pulse width, changing thermal relaxation time so that we could get patients treated. And who were the first patients that we were treating? It was actually just Fitzpatrick type 1 patients who had just really pale skin. They were the only ones that could take all of this energy. But that wouldn't be a great treatment if all we could treat was just Fitzpatrick type 1. So what had to happen is the technology had to improve for us to be able to do this. And it really didn't get there till about 2005, 2006, and 2007. So for 8 years, I was doing free treatments for patients, experimenting on energy levels, pulse width, thermal relaxation time, and all that till we finally could get a protocol that would actually work for these patients. What's very interesting now is that we have a bunch of new technologies. They're so much better. I think they're third, fourth generation compared to what we started with. And this is why there's other lecturers here saying, you know, we could use this technology and this technology and this technology because it's so much better and we've made improvements. And the biggest improvements that we've had to make is the one thing I realized early on is that the closer that you can get to the lid margin and the ability to treat right over the meibomian glands is where you're going to get the greatest efficacy. So in the beginning, when I was treating right here at the lower cheekbone, nobody was treating the lids. Dermatologists, plastic surgeons, estheticians, they would say, don't treat the lids, don't treat near the lids. What I noticed is here, you just don't get efficacy that would actually be statistically significant. And the only way that I can get statistical significance is getting closer and closer to the lid margin. Why is that? Why is that? The reason is, if you ask me what is the most important mechanism of action when it comes to IPL, it's photobiomodulation. That we actually are stimulating the cells in these glands to work better. So that is the number, there's a bunch, I'm going to show you other mechanisms of action, but that's the number one mechanism of action. So what's another reason why I know that this is the mechanism of action? Because once I started doing IPL, I started experimenting with other aesthetics technology that we had in our clinic. So I was trying, does an erbium laser stimulate the glands to work better? Does a CO2 laser work to stimulate glands to work better? Does radiofrequency, does microneedling, any of these things? And what I found was those things help the skin, and if you help the skin, you are going to make dry eye a little bit better. But they were, in terms of clinical significance, they were down here in terms of exciting and getting those meibomian glands better, especially when you get into patients who are moderate to severe. So then what's the next thing I started experimenting with? Well, if IPL works, are there other lights that actually work? And so that's why in about 2008, I started doing work with low-level light treatment. And I found low-level light treatment, if you look at the studies that we've presented and the papers that we published, that IPL works here in terms of improving meibomian gland dysfunction, tear breakup time, the signs and symptoms, and then low-level light is here. So if you ask me what are the chain, IPL is number one, low-level light is number two, and then all these other things that we're trying, electricity, RF, microneedling, they're over here. What's another reason why I know that is the order that you're going? What started this whole anti-aging thing was we were sending people out to the space station. So now, you know, Elon Musk wants to send people to Mars. And he's saying, okay, we're going to send people to Mars. And I know I'm on the first slide. See, that's why you shouldn't cut my slides. So we want to send people to Mars. So what they're doing is they're sending people to the space station to see what happens to people when they're out in space. And you know what's the number one thing that happens to people out in space is their metabolism slows down. Their mitochondria slows down. So the first group of people that they sent to the space station, they said, okay, you're going to spend a couple of months there and then come back. Those people came back and they aged incredibly. Their bodies aged, their skin aged. They go, oh my gosh. We can't send people out there for a year. They're going to come back and they're going to age 20 or 30 years. So what they started to do was they started to experiment on how can we get people's metabolism, get their mitochondria working like they do on Earth. So they experimented on all these things. They tried electricity. They tried food. They tried diet. They tried supplements. And what was the only thing that worked? Was light. So when you go out in the space station now, you have to spend some time with these wavelengths of light stimulating your body to work better. So when they found that out, that's how this information came down here to Earth. So that's why you see infrared being used. I think the last time I was here, I told you I tore my Achilles, and they said, oh, if you tear your Achilles, you won't be able to play for 9 months to a year. Well, I put infrared for 8 hours a day on my Achilles after my surgery, and I was playing 3 months later, right? So they brought in infrared, they brought in low-level light treatment, they brought in intense pulse light. And so that's why light is so important. So there's so many reasons why light works, and it's not just because it's an aesthetic treatment. So with that thinking, so this is the way I approach a dry eye patient. The first thing that we're taught when we're becoming eye doctors is what? Look at the eye, right? We ignore everything else. So what are the treatments that people are making? There's a bunch of money being spent on making new drops, right? There's a bunch of money being spent on supplements, which is good. So I'm not saying these things are bad. But if you look at all the definitions of dry eye, they all start with the eye. And I'm saying that that's the wrong place to start. So I'm going to give you my definition. Dry eye is not an eye problem. So stop thinking it's an eye problem. What is the main source of the problem? The problem is it's a skin gland problem that's affected by our system, our systemic inflammation. So why do I know that? How many people here are seeing more dry eye than they've ever seen before? Right? We all are. Why is that? Well, we're not eating well. We're sitting in front of these devices, 24 hours a day. If you're not on Netflix, you're on your phone. My wife's on TikTok all the time, just sitting there. We're not eating well. We're not exercising well. I see the young people. So we have 3 daughters, and we're constantly going, hey, it's, get some good food in you. Get a good meal. Or go exercise. So we have a pre-med daughter now that we have to actually tell her, go outside. Go get some exercise. These kids aren't exercising. They aren't eating right. They're not sleeping right. And this is why you're seeing this increase in dry eye. One of the most important things that I learned from looking at anti-aging is that as you get older, your whole body slows down, that your mitochondria just naturally slow down. The other thing, what happens when you get older is that things like CoQ10 and NAD, all these things that stimulate the mitochondria to work better, they all drop down, naturally drop down. So if you look at basal tear secretion as you get older, what happens to basal tear secretion? It just goes down. So what we have to do is we have to stimulate people inside, first of all, get them the nutrients that will get their mitochondria working, and then start improving the skin, and then stimulating the glands to work better. So 80% of rosacea patients have dry eye. Acne patients have dry eye. Aging patients have dry eye. So what you want to do first is, instead of going straight to the slit lamp, just take a look at the patient. See what their skin looks like. If their skin is bad, I can tell you their meibomian glands are going to be bad. If their diet is bad, I can tell you their meibomian glands are going to be bad. And then they have all these things that we already know about that we see on exam. But slow down, don't go straight to the eye. Start thinking about skin, start thinking about glands, start thinking about activity, and start thinking about what these patients eat. So that's how I found it. I started doing rosacea patients. Those patients, their skin got better, and some of those patients, their dry eye got better. So I got a grant, and then I started getting patents on light treatments for dry eye. And he went through a great, I think that was probably the best science lecture that I've ever heard on IPL. That was a wonderful lecture. Totally prepared. So I don't have to do a lot of this, but what I do have to say is that the reason why we're able to do patients' lids is that we have control over joules, pulse width, and thermal relaxation time. So instead of giving that thin skin of the lids all the energy at once, we can pulse that energy. And why can we do somebody who's Fitzpatrick 2 or 3 or 4, and now I'm doing 5 and 6s? Because instead of giving them all the energy at once, we can do some thermal relaxation time. So when you hit somebody with IPL, what happens to that energy? That energy actually is diffusing through their skin. Now, if you do a high dose of energy and then right away give them another high dose of energy, there's no time for that energy to diffuse and you start breaking down skin. So that's why if you want to, whatever system you're using, if you want to have the ability to do darker and darker skin types, you have to start playing with thermal relaxation time. And once you start learning how to do that, then all of a sudden the world of a lot more patients opens up to you. So here's some mechanisms of action. So we've already went through them. That wavelength of 600 to 700 actually, that is a wavelength that is absorbed by oxyhemoglobin in these telangiectasias. So that's one mechanism of action, that you're closing off these blood vessels that are secreting inflammatory mediators. And then what's been shown in the dermatology world, and we showed in the eye world, is that IPL on the skin actually decreases the inflammatory mediators that break down the skin. The number one inflammatory mediator that decreases on the skin is interleukin-17. We showed that patients with dry eye, the most specific inflammatory marker on their eye is actually interleukin-17. T cells make T helper cells, and T helper cells make interleukin-17. That's the reason why cyclosporin works, because it's a T cell immunomodulator. It's the reason why if you're going to have a drop that's actually going to help somebody with dry eye, specifically, you want something that regulates T cells. And we showed that IPL actually decreases interleukin-17 on the tear. So there's other mechanisms of action. It can kill microorganisms, but I can tell you Demodex is a very difficult mite to kill. They bury themselves in pores. We've shown on video that if you hit a open Demodex with these wavelengths of light, you can kill the Demodex. Is it the light affecting the bacteria inside the Demodex, or is it doing something to the structure of the Demodex? We don't know. And then closing the telangiectasias, killing microorganisms, but the number one cause is photomodulation. And then heat. So what does heat do that is making this a mechanism of action? It's been shown that when we're doing a CO2 laser or we're doing IPL, we're generating heat in the dermis. And what that heat does is, if it's not too hot and burns the skin, what it'll actually do is it'll stimulate the DNA to produce heat shock proteins. Those heat shock proteins actually will signal the DNA to work better. So that's why when you do a CO2 laser or an IPL, that these patients' skin looks better, because it's making heat shock proteins. A warm compress is not going to make heat shock proteins. That's one of the first questions that I get. I always talk too much. So the FDA study. So the Luminous system is the only one that has FDA approval specifically for dry eye. We did the study on the FDA study on IPL, and I think it's the best study possible because we actually had sham with expression versus IPL with expression. And what we showed is, and you said it didn't go back very well. What we showed is that we improved the signs and symptoms of dry eye. One of the questions that I get is, should you express after every IPL? What's my answer? Should you express, what's your guys' answer? Should you express after every IPL? Yes. Yes. The reason being is, take advantage of the fact that the IPL actually, that energy that you're generating in the dermis is melting any type of thick secretion, and it's causing dilation of the gland, so you can express these glands. If you don't express the glands, what happens is those secretions sit there. You know, they dissolve, but they don't actually leave the gland, and they sit there. So express after every IPL. I'm almost done. I know I'm getting close. I actually wrote a paper on the physics of expression. So if you're using a metal expressor, look at that article, why individual expression with a silicon tip is actually better in terms of expressing. So we showed improvement in tear breakup time. We showed a statistical improvement in OSDI. But the reason why photomodulation is so important is we showed that glands that weren't working after you do IPL, those glands come back. So I get questions from patients all the time. If I have glands that are dropped out on my biography, if you do IPL, will those glands come back? They will. And then how do we do the upper lid? This is the thinnest skin of the whole face. How are we going to be able to do that upper lid? And we figured out is with a smaller tip. So we're not getting all that energy as he was describing before, and we can control the energy. So that's how that Optilite, it was from these experiments with that small tip that we realized that we can actually do the upper lid without having harm and causing injury. And multi-pulse, a chiller, good ergonomic design, and I know I'm going to be giving a lecture on that. What is the future? I think the future of diagnosis, my biography is great. The problem with my biography is if somebody has dropped out glands, you could do IPL, you're not going to see those glands come back in a month or 2 months. It takes months for those glands to come back. But what we've shown is all dry eye patients have abnormal confocal microscopy. But if you treat them with IPL or you treat them for looking at nerves with PRP, which I described the last time I was here, or Oxervate, you could bring those nerves back. But what we're showing is immediately after 1 or 2 IPL treatments, you start to see changes in the confocal. I have a New York clinic if you guys ever want to come visit and learn some more. This is we're going to do a little bit on low-level light treatment, but this is the new Q. This is the new low-level light treatment system that we have. And I think when we get in questions, we're going to talk about low-level light treatment. Thank you.